All right, welcome to the first episode of my podcast. Haha, just kidding. Um, these are gonna be questions. They're step two levels, and the topic is respiratory immunology and what is the other one? Shit, respiratory immunology and hematology. And the challenge is how far I can go before I drop or before the sun rises. It's 9:34. I was just bored, so I thought I was bored studying, so I thought I should film myself study um, and put it on YouTube and get rich. Yeah, that's the thought behind it. Um, yeah, so I'm gonna read the questions out loud, but not the whole question, because obviously it would be a copyright infringement if I do that. Um, but I'm gonna basically think out loud, okay? And then I'm also gonna forget that I'm being filmed. The goal is to just like study basically, like as long as I can. And this is a step two level video, so I guess there's some step one questions here and there, but it's a step two. If you haven't written step one, or if you're not studying for step two, it's not useful for you. Also, it's probably not useful for you anyways, unless you're really smart, you know, that you can read in between lines of what I'm thinking. Okay, so we have a 25-year-old female, G2P1, considered ED at 39 weeks in active labor. Okay, okay. Her first child was delivered at 40 by elective C-section due to limited range of motion of her hip. Okay, whatever. It was elective. So the patient has sickle cell. Okay, this patient has sickle cell. We still don't have a chief complaint. Well, she's in active labor. Um, as had coronary acute chest, multiple episode of acute chest syndrome. Okay, because just sickle cells. Got on transfusions in the past because of the sickle cell. So we have a person with sickle cell who is it, who is giving birth. That's our picture so far. Uh, we do another C-section. Baby is born. Mom loses half a liter of blood. It's kind of like not that much, average. I don't know, I've seen more. She receives cefazolin as you do before any surgery. Patient continues to bleed after surgery, and she receives 1 unit of RBCs. Okay, 1 hour later, has flank pain and is in acute pain. Okay, flank pain and acute pain. Someone who's been bleeding a lot has flank pain and is in acute distress and now is hypotensive. Foley catheter is showing dark brown urine. What does this patient have? Okay, probably like probably the RBCs cause something, right? Um, the RBCs cause some sort of hemolysis. That's why. So what you have to think of is be like, we have what do we have? What we have is like clinically we have fever, okay? We have dark brown urine. Dark brown urine is suggesting hemolysis. Um, I swear to you guys, I'm a little nervous since I'm filming myself. Usually I'm faster than this. Um, okay. There's an answer that says basically hemolysis, right? So what is causing that hemolysis? You got to think. Is it antibody mediated? One thought could be like, yeah, there is like an antibody mediated response. Ooh, but how does the sickle cell play into this whole picture? Right? That's also a thing. Well, I don't know about that actually. How does the sickle cell? So there is a choice that's suggesting the source of hemolysis is from like a antibody. It says like a positive Coombs test, which is like antibody reacting against an RBC, right? But how does the sickle cell tie in that to that whole picture? From eliminating the choices, I can tell that positive Coombs test is likely the answer. But what about the sickle cell? Why would they tell us extensive history of sickle cell if it's not really? How is it say? The question is how is so? I think we got a question answer is like the question is just saying positive Coombs test. That's what we are gonna see. But the other thing is we gotta figure out how does the sickle cell play into this whole picture? How does the pregnancy, the blood loss play into this whole picture? Is that just a setup for getting a transfusion? It seems like, hmm, I don't know. Let's see. Yeah, obviously the answer is right. It's an acute hemolytic transfusion reaction. You most likely because of ABO incompatibility. And the way we know that is because we have those beautiful dark urines suggesting that there's hemoglobin in the urine. So, okay, so that's what this. All right, so the first time you're receiving ABO incompatible blood, you're not gonna kind of like react. You're not gonna hemolyze them that fast because you're kind of not super sensitized to them. You're still gonna hemolyze them somewhat, but this person, because of previous history of transfusions, that's how the whole sickle cell ties into it. This person has been getting transfusions, right? And now uh, it's probably sensitized to the ABO incompatibilities, and now it's bursting RBCs right and left, and that's why. So it's allo-immunized against them. Yeah, let's see if there's anything that I didn't pick up. See, I told you, like the sickle cell has to play a role here. It's not just a setup for receiving transfusions, right? It's because of allo-immunization. Allo-immunization. All right, let's go. Next question. 2 weeks after, okay, I'm not gonna read the question, but someone received an allogenic stem cell transplant, okay, for multiple myeloma. Allogenic meaning they got it from someone else. So maybe it's a graft versus host disease question. I don't know. Uh, and they get a rash, abdominal cramps, yes, diarrhea, whatever. This is a graft versus host question. Why do we get graft versus host? Because it's allogenic. It's not autogenic. They got it from someone else. They got the stem cells from someone else. They also have jaundice, the hemolytic anemia because of the whole autoimmune nature. Okay. ALA, ALT is high because of RBC lysis. And then the question is asking, what's the cause of this? This patient's condition. Hmm. I think it's a T cell driven response, right? So, and obviously it's the donor's T cells. Um, yeah, so donor T cells are causing the problem. Okay, 2 from 2. The two questions both right. Let's see how far I can get we can get this streak going. 2 for 2. Let me actually write it down somewhere. 2. Mm, all right. Any interesting information? Oh yeah, the other thing is acute. There's acute and chronic graft versus host disease. Acute is within 100 days. I don't know how the chronic one presents. I know the acute one is really intense. When I worked in BC cancer, I know that like a couple of trials were about acute graft versus host disease. What a shitty thing to have. Okay, so this question has a radiology finding that's quite intense. Okay, let's see. So, guy in his 40s has kind of like dry cough for we don't know for how long, fatigue, dry coughs, breathing symptoms or respiratory symptoms for 2 months. He's a minor. Okay, whatever. That makes sense. That is X-ray so fucked up. He's on some hypertension medication. Has had asthma when he was a kid. Some smoking. He's not in respiratory distress. You hear crackles. Okay, crackles are the same thing as rails, and they're popping sounds that the alveoli make. No rhonchi. Rhonchi is a wheezing sound. So rhonchi is in the bronchi. Rails are in the tails being the alveoli. And there's a chest x-ray that just shows, I don't even know how to describe this chest x-ray, but so some sort of like, ooh, I know what this is. I think maybe some sort of like mineral exposure, right? Like those pneumoconioses with the minerals. But just based on x-ray, I don't know if I can answer it. The first thing that popped into my mind was the silicosis being associated with tuberculosis, but I don't think that's that, or at least like I'm not 100% sure if that's what you're looking at. That's what I'm looking at, and you don't exist because no one watching this video, hopefully. Otherwise, it would be really embarrassing for me and for you. I actually think this is pretty useful for the right person. No, I don't think that. Um, so this question should give me an idea that of which one it is, right? Which one of the kind of like mining associated syndromes, let's call them. This is, but the question doesn't really give me any clues. Ooh, fuck, this is hard. So the most of the damage is in the upper lung fields, and remember one of them was associated with the upper lung fields. There's not hilar lymphadenopathies, and sarcoid is an answer, so I don't think it's a sarcoid. Right, there is the one that's like anthracis, whatever, the one that's like associated with carbon particles. That's not it, because obviously this lung, because that one is usually like a just a incidental finding. That's not a pathology. the anthracosis. This guy definitely has a pathology, both radiologically and like clinically. Hypersensitivity pneumonitis actually is not it. That's the one you get from like birds, bacteria, like fungi, chronic exposure to like biologic matter. We have borreliosis and silicosis and asbestosis left. I don't think this is asbestosis. Um, between borreliosis, asbestosis, I remember it's most of the destruction is in lower lung fields. I might get this question wrong. This is in the upper lung fields. Silicosis. I'm gonna go with, so I know silicosis has like calcification, eggshell calcification of the hilar lymph nodes, and we don't see that here. So I'm gonna go with borreliosis, and I think I remember that one being associated with the upper lung fields. But I'm not super, I'm probably like 30% confident in this question, and I was wrong, okay? Apparently, there is eggshell calcifications. I'm just blind. So, well, there isn't, but let's see. This is a good question. Every question you get wrong is a good question because it teaches you something. So berliosis is like in the aerospace, like high-tech industries, not mining. And causes a restrictive pattern. So what the fuck? Oh, so I'm gonna take notes. Every time I get a question wrong where I come across a point, I take notes. So ber or berliosis is um caused by caused by beryllium, and is seen in high-tech aerospace. How do you write aerospace? Aerospace plus nuclear shit, you know, nuclear industries. Industries. If I wasn't doing medicine, that's what I would be doing. Aerospace shit. Uh, mm, oh, this is important. Causes restrictive pattern. Pattern. Okay. So this is polysilicosis. As minor should have given the way silicone is like the most common thing on earth. Silicone or whatever. Okay, silicosis. Uh, let's see what about this guy. So silicosis is silicosis is associated with, what is silicosis is associated with? Okay, eggshell calcifications we already know. Eggshell calcifications. Hilar lymphadenopathy, okay. Lymphadenopathy, okay, fibrosis in the upper lobes. Upper lobe nodule, fibrosis plus upper lobe nodules, which I'm gonna underline because that would have been the key to answering this question, right? I did notice the radiology is like uh predominantly upper lobe. I think so. Silicosis is predominantly upper lobe, and asbestosis is predominantly lower lobe. That's the, and berliosis is like unrelated, fucking high tech aerospace. I think berliosis had one like key point, but I'm not done with this question yet. I need to uh, dig deeper. So multiple like nodules, specifically like you see nodules here. Oh, which reminds me, maybe my patient has some shit like this. I should have. So I have a guy with like a kind of a shit, like a messed up like lung thing. We don't know what's going on with him. Maybe I should have asked him what work he does, since he's not from here. So he could literally be a minor also. Um, Also, there's evidence of. I'm gonna add this in. There is also evidence of fibrosis um, close to the diaphragm. Cool. All right, my streak is reset to 1 again. Wow. I think the highest streak I've had is like 20 or something on Amboss. Well, this is similar to U-World, which is like um all the anything that's useful, anything else is bullshit. Okay. Now we have like a 60s guy has dyspnea, has dysphagia, swelling in the neck and jaw. Has tooth pain left sided over the past week, which has made it difficult for him to sleep. So I think Ludwig was it called? Right now what I'm thinking is maybe he's got cellulitis of the floor of the jaw. Cellulitis of the floor of the mouth, which is I think called Ludwig's angina or some shit like that. But let's see. So a week ago he had some sort of a sore throat. That 4 weeks ago he had some sort of sore throat. Like a month ago, it's type 2 diabetes. Okay, I'm just taking some anti-diabetics. His BMI is high, whatever. He has fever, low blood pressure. Okay, not super low, normal blood pressure, probably low for him. Um, there is pus in the left molar. That's like there is anterior neck tenderness and swelling. Okay, the leukocytosis. I think the glucose is really high. Which of the following is most likely diagnosis? The Ludwig angina thing that I said is an answer, but I because we have pus expression, I would think like an abscess in that area is probably a better answer. Uh, the question is has peritonsillar abscess, but obviously the pus isn't coming from the tonsil, it's coming from the molars. So I'm gonna go with Ludwig's angina or Ludwig angina, and I think I'm right. Yeah, of course I'm right. So it's remember it's like cellulitis of this area, like here. Um, I mean, if you have diabetes, you're predisposed. Okay, that's not a shock. Probably has shit like oral hygiene. It's probably a risk factor. Okay, so this is key, which is treatment for it. So I haven't really thought about it. Obviously, you want to give anti-IV antibiotics because it's pretty serious. You want to give it so like a broad covering, so Zosyn and meropenem, or meropenem, plus drainage, plus airway. All right, cool. You gotta drain and you gotta take care of the airway. Okay, so old 60s woman, so our streak is back to one. Um, Abdominal pain during this period. She's night sweats. Okay, so old lady, 3 weeks of like fatigue, has night sweats and weight loss. I'm thinking some sort of lymphoma versus TB. Okay, that's what comes to my mind. Swelling of the anterior neck for a couple of days. Okay, still more leaning towards the lymphoma. Taking a quick peek at the lab results. Lactate, nothing is really jumping out to me. It's making me narrow it down to one of those things. Oh, yeah, you have a big fixed lymph node and and splenomegaly, which means it's the lymphoma rather than the TB. Um, okay, CT also shows multiple lymph nodes fucking being involved in the mediastinum everywhere. Um, so it's above and below the diaphragm, which I think makes it stage 3 lymphoma. And they positive for CD20. Obviously it's a B lymphoma. And the question is, it says it's like they're highly proliferative on biopsy. It's kind of trying to tell you it's a pretty bad looking B cell lymphoma, which is another name for another way of saying diffuse large B cell lymphoma. It's literally, if you look at the dictionaries, those two words are synonymous. Let's see if there's anything in the question answer that we didn't think of. No, nothing, absolutely nothing. I would have liked to seen like a here, lymphoma staging, and then obviously fucking it suggests me lymphoma staging for dogs, which is who the fuck gives a shit about how dogs lymphoma stages. Alright. So stage 1 is just one series of lymph nodes involved. Stage 2 is two series of lymph nodes involved, two or more, but they're on one side of the diaphragm. The reason diaphragm is significant is because the lymphatics, like there is only one way to cross. Like all the upper ones are connected, all the lower ones are also connected, but between the diaphragm, upper and lower, it's like that one tract that connects both of them. So if it's on the both sides, it means it's distributing it's expanding upwards and downwards. So it's like it's a good border separating the upper section versus the lower section. So 3 is having some lymph nodes upper and some lymph nodes lower than the diaphragm, and then 4 is obviously organ involvement. All right, thank God I kind of knew that. Okay, our streak is back to 2. 67. Okay, whatever. Some year old woman, old lady, like late 60s lady, chest pain, progressive shortness of breath with exertion, and weight loss. Okay, whatever. Same picture actually. Weight loss and pulmonary problems. Maybe cancer this time. Who knows? Cough. Okay. Yeah, I'm thinking right now. I'm thinking TB or cancer of the lung, or maybe metastasis to the lung. Well, actually, has COPD, so who knows? History of COPD. She worked in a wiring shop. Hmm. Hmm. Okay, so I think I know what I'm dealing with on the radiology. Like the pleura of one of the lungs looks really thick, but you have to like have an eye for it to see it, and that's a mesothelioma. Mesothelioma is a the pleural tumor, right? So we know it's a lung cancer. The lung fields are clear, but then one of the lungs is like much smaller. And then when you look at it clearly, you're like, oh shit, this lung has like almost a wall around it. So that's how mesothelioma spreads because it's a pleural tumor. So yay, our streak is at 3. We broke the last streak at 2. Um, let's see if it says anything. The wiring job supposes a asbestosis or asbestos exposure thing. Okay, okay. The question says, or prognosis is 12 months after diagnosis, which is quite a lot. Like it's one of the worst ones. It's pretty bad, pretty bad. So we got a young woman. Uh, it's a left-sided chest pain that's like really sharp and seems kind of pleural. Yeah, yeah, pleural setting. It could also be like a pericarditis picture. Actually, it's likely pericarditis, I think. Uh, so like whatever. Oh, she's also a medical student. She like drinks a little bit of alcohol, doesn't do drugs, sure. Um, takes oil. So like has pericarditis from what I get. Now, does she have lupus or is it like idiopathic? What is causing that? That's the next question. You also hear friction rub, so it's pericarditis galore. Um, most likely, most of the times, it is indeed idiopathic because of like a virus, and you treat it supportively. I think now the question is, you just give them ibuprofen and tell him to fuck off, or do you like? My thought was maybe we also want to do an echo to see like if there's too much effusion or whatever. But question doesn't give me that choice. Question tells me CT angio, the closest thing that's like an imaging thing, which is too much, obviously. Um, so I'll just. Ooh, the other thing to make sure is that like you want to rule out like a bacterial pericarditis, right? So, but none of the choices, which I think you would want to get an echo. That's the only like thing that makes sense to me. But I think you just supportively treat it. Yeah. Let's see what they say. I mean, you can also do an EKG. They're saying if you have pleuritis, then you do an EKG to exclude pericarditis and coronary disease because that sometimes can mimic pleuritis, like a lung originated pleural pain. Um, yeah, but in this case, we just do it supportively. I don't know. That question didn't sit well with me. I think that was the fourth question we got right in a row. Okay. All right. First thing jumps at me, this patient's platelets are through the roof. Okay. So what am I thinking of when I see that? Maybe they have some sort of lymphoproliferative disorder. That's my first thought. I know there's like weird things like juvenile arthritis that also causes high platelets, just random. And I know like some other things also cause high platelets, like not having a spleen. Nothing sneaky. Or oh shit, I need to do the firecracker quiz. I just remembered. 50. So we got a against 60 something year old woman. A couple months of fatigue. Weight loss. Large in spleen. Makes sense. Got glucocytosis through the roof, really high. Platelets really high. But RBC is not that high. So how do you treat this patient? Blasts are only at 5%. If blasts are more than 20%, you're thinking of like a leukemia picture. So this lady probably has like a CML, I almost want to say. Yeah, I almost want to say CML. No, because Let's see how the lymphocytes are tiny. Lymphocytes are like a tiny fraction of the whole thing. So I think she has CML, chronic myelocytic leukemia. How do we, what do we do next? So if we think she has CML, we got to confirm the diagnosis of CML. How do you confirm the diagnosis of CML? CML, you want to see the Philadelphia chromosome really, because that's, you can only have CML if you have that. And so I think cytogenic studies is warranted at this point. And then if that's the case, then we can treat her with imatinib, I think, and like stuff like that. Let's see. Serum protein electrophoresis. No. Let's look at the other choices. One of them is like therapy, like some bunch of um, chemotherapy stuff, which you don't want to treat before diagnosing, especially something as serious as this. Another one is observation of follow-up. That's too lazy, I would say. It's not too lazy. This is something that could be serious, so you don't want to just observe it. So yeah, cytologic studies. Exactly, you want to look for a Philadelphia chromosome and then treat with imatinib or whatever else works like imatinib. Right. So the other thing is you can have high thrombocytes with CML. It's like kind of like myeloproliferative diseases don't have borders like they do as their name suggests they would. Let me just put it that way. Let's see if there is anything else that this question offered that I didn't catch on to. Mm. So in the differential of the white cells, there's metamyelocytes, which is an immature granulocyte or a myelocyte, which is a sign of ooh. So we got myelocytes versus metamyelocytes. So myelocytes are immature metamyelocytes. If there is more of them, uh, it suggests myeloproliferative proliferative disease. Okay, that was the fifth question, boys and girls. 6 week. Okay, so again, someone had a allogeneic stem cell transplant at age 9 because they had Fanconi anemia, and they developed like shit ton of diarrhea, skin rashes. So it's also a GV, graft versus host disease syndrome or disease. Um, Question. There are a bunch of diseases. There are on a bunch of like both immunosuppressive and antiviral, antibacterial stuff. Uh, Fanconi anemia is like kind of like when your stem cells don't really want to do anything. I believe it's because they have some sort of like repair DNA repair problem, so they like die off early or something. Uh, it's kind of like accelerated aging of your stem cells. but that's something to read about. But this kid has like everything basically. He has like jaundice, has the diarrhea, has the rashes everywhere, and then kind of like, what's the diagnosis? Like, yeah, graft versus host. Okay, guys, this is our sixth question that we got right in a row. That I got right in a row. Don't take credit for it now. Um, okay, obviously it's a type 4 hypersensitivity. All right, and then let's remind ourselves what Fanconi anemia was quickly, rather really quickly. I don't have time for step one, step one bullshit, you know. But so it's a form of aplastic anemia, as I described earlier. So they have a thumb and formal malformation thing. Osmosis due to DNA cross-linking repair. What did I tell you? What did I tell you? So characteristics, Fanconi. This is different than Fanconi syndrome, by the way. Is it? Yeah, it is. Yeah. Fanconi syndrome is when your proximal convoluted tubules can't do shit. They can't reabsorb. It's like you get renal diarrhea. Fanconi, where am I? Anemia. It's autosomal recessive. It's DNA repair impairment. Uh, that leads to bone marrow failure. Literally what I described. We have short stature, hypo or hyperpigmentations, cafe eluded spots, microcephaly, developmental delay, and thumb and forearm malformations. So I think short stature, and then you got thumb plus forearm malformations. Bunch of other abnormalities. So, and the other thing is about 50% of them develop AML. What a great disease this is. Or myelodysplastic syndrome. It's one of the best things we can have. But one day, hopefully, people, maybe 100 years from now, they won't be as big of a deal as they are right now. Okay, CBC shows pancytopenia, microcytic anemia, retics will be low, your EPO will be high. You can give granulocyte monocyte clonal stimulating factor stuff. You got to give immunosuppressive therapy. Why? I don't understand that. Maybe because they have autoimmunity as well, and then obviously another form of treatment is stem cell transplant. But this shit, the graft versus host disease can happen, and it's pretty grim when it happens. Okay, that was our sixth question, right in a row. Not to show off or anything. All right, we got a 61-year-old or 60-something-year-old with HIV. Now, my question is, number one, is how well is it controlled? I see later in the question, it says 67. the CD4s, so I just have that in mind. Has had fatigue, cough, worsening shortness of breath. No, it's oxygen 87. Uh, okay, is this gonna be we do a lavage, we see disc-shaped yeast. Now, what the fuck was these disc-shaped yeasts? Disc, okay, that's PCP, isn't it? So I think, and the question is, you want to treat it. The treatment for this is also protects you against what? Actually, I don't know if disc-shaped is disc-shaped yeast. How does PCP look? I'm between PCP and Cryptococcus. Cryptococcus. 67 is most closer to Cryptococcus. PCP is 200. Well, which means I think Cryptococcus is 100, so you can have either. Doesn't really give us much. But I think the treatment is like a version of TMPSMX, basically. Not TMPSMX itself, but a version of it. So the fact that the question doesn't give PCP as an answer, I think this person currently does have PCP. The next question is, how do you treat PCP? Which I think the answer for is not trimethoprim, but another form of it. That's the same drug that guy. Remember back in the day, some guy bought a drug that was like an AIDS drug that like jacked up the price like 700%. It's that drug. Um, I'm not good with names, but it starts with a T something. Oh, obviously we'll see it, but I think it protects you against Cryptococcus. Yes, or I'm between Cryptococcus and Toxoplasmosis. Because I know it could also be a good Toxoplasmosis. Hmm. No, what the fuck am I thinking? So Cryptococcus is a fungi. It requires fluconazole shit like that. So I'm gonna go with Toxoplasmosis. Guys, might destroy our streak of 6. We didn't. You get lucky once. Hopefully, I won't have to guess-ish questions like this anymore. So yeah, primary diagnosis is PCP, and you drug PCP with trimethoprim. No, trimethoprim. You you do it with trimethoprim. You treat PCP with trimethoprim. That's weird. I thought trimethoprim sulfamethoxazole was the treatment. Okay, let's take a quick look at treatment for treatment plus prophylaxis for PCP and toxoplasmosis. Uh, okay, interesting. So, um, For alternatives to trimethoprim sulfamethoxazole for um, mm, for PCP treatment, PCP or actually cysto. What is this one? Cysto iso. Okay, I don't know this one. But so for PCP, alternatives to TMPSMX are dapsone, I think atovaquone, yeah, quinn. Is this treatment or this is prophylaxis? Well, hopefully it also says or dapsone. Did I say dapsone? Yeah, dapsone or pentamidine. Pentamidine is the one. It doesn't start with P. That's the one that was saying like the guy that jacked up the price. What's his name? I don't know his name either. Martin Scully or something like that. Pentamidine. I think this is a drug that he jacked up the price of. Here, Martin Scully. Who is the guy? Who is the guy that increased AIDS medication price? Martin Shkreli, Pharmabro. Drug. What drug was it? Daraprim. Daraprim. What is Daraprim? Okay, no, fuck this. Premethamine. It was premethamine. Similar. Pentamidine. You see how? But they do kind of similar type of shit. Um, so for toxoplasma, you also give trimethoprim sulfamethoxazole. And how about cyclo for coccidomycosis? You might want to give fluconazole, but cryptosporidium, not cryptosporidium, cryptococcus doesn't have a prophylaxis. Okay. All right. Ooh, the thing is, so now toxoplasmosis. So PCP, you treat and prophylax with the same thing, but with toxoplasmosis, I think you treat with something else. You do prophylax with TMPSMX, but you treat with this. I'm gonna write. Oh, here, permethamine. See that this is the Daraprim drug that guy jacked up the price up. So for toxoplasma, treat with permethamine, premethamine plus sulfathizine plus leucovorin. Leucovorin. Or if pregnant before 18 weeks, spiromycin. All right. So you only treat this for in yeah. So I guess the pregnancy thing is actually important. And premethamine, sulfadizine, and leucovorin. Cool. It's hard to remember this one, but it will come to your assist. Was this the sixth question I got right in a row or the seven? 1, 2, 3, 4, 5, 6, 7. 7. That was the 7. It's a personal best for me today, I think. Well, at least since we started this video. Now we got a 60 something year old living assisted living family. Shortness of breath for 5 hours. No fever or any like fever, chills, nausea, vomiting, diarrhea, whatever. Nothing is. ROS is negative. That's COPD. Okay, is this a COPD exacerbation question? Because if it is, I've had like 10 patients in the past 4 weeks of this. Uh, okay. Uh, what information is this question is gonna give me? So she's saturating at 86%. Okay. Atrial blood gas shows expiratory wheezing. We put her on 2 liters of oxygen. O2 sat goes up to 91. Give her some steroids, some nebulizers, some antibiotics. We put her on 4 liters of oxygen. So I think the question is going to be, so PCO2 is persistently high. The question is, what do we do next? I think she's doing fine. The PCO2 is a little high, but she's oxygenating well. She's at 92%. I think you just leave her on high flow oxygen. That's what I think. And I'm wrong. Shit. She's acidotic. She's pretty acidotic. I didn't catch that. pH is low and getting lower. And PCO2 she's retaining oxygen. So in that case, we probably want to ventilate her non-aggressively, like a 5 hours or something. We want to jack up the respiratory rate. Yeah, BiPAP. That's actually a good point because shit, lost my streak, guys. Um, so pretty sad when I get a question wrong. So when you have basically acute exacerbation of COPD with respiratory acidosis, such as in respiratory failure, uh, and high PCO2, that's not responding to high flow. Actually, I just realized my patient has exactly this. High flow O2. Then we wanna non-invasively, well, not this, like with a mask. Uh, Invasively respirate. Ventilate. Ventilate. If fails, then intubate. I fucking hate the fact that I lost my streak. But it's an important thing that I learned. So, all right, next question. Patient, I like immediately see lab values. Patient has like okay folate and okay vitamin B12 and really low reticulocytes. What's going on? Bone marrow is failing for some reason. We don't know why. And MCV is high, so we really don't know why. Let's look at the answer choices. They're all leukemias and shit. So we gotta see what other symptoms the patient presents with. Okay, exercise intolerance, dizziness, big liver. Oh, anisocytosis. Anisocytosis. What was that? Polycytosis means cells have um yeah, anisocytosis means cells have different sizes. I think. Oh, bone marrow aspirate shows ringed sideroblasts. How do you develop ringed sideroblasts? This is a good question because I have no idea how would I how like a lymphoproliferative disorder that is not like yeah, basically a lymphoproliferative disorder is leading to this. And I have no idea how. Ringed sideroblast. Oh, it's not a question like that, I don't think. Maybe she has this is myelodysplastic syndrome. And the question is saying what does the person has an increased chance of developing? And maybe the answer is AML. So you're having a bone marrow failure, right? And you can tell that it is from the RBCs themselves. Nothing is fucking kicking those RBCs out. Nothing is fucking with them. It's them. Why can I say that? How can I say that? Is it because the MCV is high? Not really. It's because of the anisocytosis or whatever. Anisocytosis. So they're like producing shit quality. Their cerebrals are producing shit quality RBCs. They're macrocytic even though they shouldn't be because they have all the vitamins you need. So it means like your erythropoietic stem cell is like kind of shitty quality, which means it could keep accumulating mutations and eventually become an AML. That's what I think is going on. Actually, this is the only thing that makes sense. Dude, 20 something percent of people got this right, and I got it right. So again, our streak is one question. Boys and girls, we're back at square one. It was myelodysplastic syndrome. Hmm. And then the explanation is you have macrocytic anemia with low reticulocytes, which means you have dysplastic hematopoiesis, and you also have the sideroblast. You have the anisocytosis, which I'm gonna look up exactly what it means, and that's gonna go in my notebook because I don't exactly know what it means, but yeah, the different sizes. Anisocytosis, RBCs of different sizes, and then there's also polykyocytosis, poly no polykilo, any shape. Okay, so polykyo is abnormal shape. Poly polykylocytosis, RBCs of abnormal shape. Cool. Cool. We're all hematologists now. We're actually heme oncologists, all of us. What a great field that is. All right. So someone gets aortic valve replacement in their 70s, and now, okay, this is a question. So since I know this is a hematology question, probably, which in a test you usually don't know that, and it's talking about valve replacement, it's probably a macrovascular hemolytic anemia, and the question kind of shows a rapid decrease in platelets and some decrease in hemoglobin, and really or it could be like Actually, no, it's not that. It's something way more interesting. Something way more interesting. So if you when you have like a valve that's like tight or whatever, it's causing too much turbulence, uh, it might, but it does do. Let's see, actually. Hmm. It fucks with long Willebrand factor and it makes you hypocoagulable, which is persistent with this patient. Also, this patient doesn't increase their. So initially, I thought it's hemolytic anemia, but the AST and ALT from admission until now haven't changed. What has changed is platelets have gone down and like really down. That's the biggest thing that has changed. And also your APTT has gone up. That's those are and you have some mild increase in creatinine. Oh, and then imaging shows occlusion of a mesenteric vein, which which is a sign of hypercoagulability, right? But your ooh ooh, I really screwed myself by reading too much into it initially. This is just a fucking hit. This is a heparin induced patient also received heparin unfractionated. So see how I was talking myself into. So that's the thing. HIT is a hypercoagulable state, even though your platelets are going down and your APTT is going up. It's a hypercoagulable state because you have like platelets are irritated, they're overactivated, right? That's why they're low. So direct platelet activation by heparin is the answer. What is was wrong? Asshole. It is hit. Fuck, I should have read all the choices. I just saw heparin and played it in a sentence and like chose that. Direct antibody. So this is hit 2 versus hit 1. This is the first time I'm seeing like a question specifically go versus after hit 2 versus hit 1. So heparin-induced thrombocytopenia. How many days after the surgery is this? This is 8 days after surgery. So direct platelet activation by heparin is hit 1. Let's write this down. See, I get sad when I get something wrong, but I definitely do learn stuff like this, which I wouldn't have literally learned if I haven't gotten it wrong in a way, or I haven't come across this question. Hit 1 is mild, and platelets are still more than 100K. Not associated with thrombosis. Thrombosis, thrombosis. What else? Um, within 5 days of heparin use really fucked myself over by quickly jumping into a conclusion that this is probably hemolytic anemia, just being too smart. Fuck me. But I did think of hit, but I rushed to a choice because I wanted to be a hero. I didn't notice that there's two choices that talk about um basically hit, and maybe if I thought longer and harder, I would have chosen the right one. So hit one isn't associated with um like uh thrombosis, and it's caused by direct platelet activation. Whereas hit two, okay, so is antibody platelet uh, activation. So platelet factor 4 is involved. Plate, mm, let's say auto antibodies against platelet factor 4. We have thrombosis, thrombosis, consumptive platelet activation. And it says you may get bleeding, but it will be due to venous occlusion. Venous occlusions can cause hemorrhage in the adrenals. And unfractured heparin has higher chance than lower molecular weight, which is, I think I knew that. All right, next question. Wait, so that was my streak before I fucking broke it again. Guys, my streak was 1. I broke it. Oh no. Let's see. Let's say I'll go until it's like 11 here. Um, and I want to sleep at a reasonable time because I don't want to fuck up my sleeping cycle and like wake up at 2 p.m. tomorrow because Monday I have to wake up and go to work. So let's say I will go until I get 10 right questions in a row. I think that's a good challenge. How long have I been doing this? Where does it say? Has it not been fucking recording? No, it has. Thank God it has been. It's only been an hour and a half, and I think I can look how many questions I've done. Well, let's see, my. I don't know. I don't know. Fucking, I can't actually. I cannot. Well, here. 2, 3, plus 7, 10, 11, 12. This is the 13th one. So I do about, this was slower than normal. This was slightly slower than normal. I do about 12 questions an hour. You guys are slowing me down, you fuckers. Anyways, got, have a young female. Okay, I kind of see young female. I see healer, kind of like lymphadenopathy. She has sarcoid. Okay, but let's read the question so we don't get it fucking wrong again. Because I need to get 10 right in a row before I can sleep. I think that's a fun game. When like you don't feel like studying, be like, oh, I want to get 10 right in a row. And if you're like not scoring high, you're gonna fucking be doing this for the rest of your life. Um, I've got up to 7. I think I can make 10. Actually, if in order to make 10, I will need to think a little harder. So, lady is like incidentally is found to have hilar lymphadenopathy, and then so she has asymptomatic. Uh, I think you don't do shit for them. She has asymptomatic sarcoid. I think you just observe them, but I think it's one of those things you just observe. Yes, you don't give them glucocorticoids. The thing is, they will get spontaneous remissions. That's one thing to keep in mind. Why is this too like in my face almost? Yeah. Let's see if the settings are. This eye is a little red. This one. Alright, whatever. So you keep examining them every 3 to 6 months to kind of assess pulmonary function. And then if they're symptomatic, you give them. If they're symptomatic or if they're extrapulmonary, this is ocular cutaneous symptoms. So if you're one of the guys or girls who always says, "Oh, if it's asymptomatic, you don't treat, then you're gonna find yourself in shitty situations," because sometimes you do treat if they're asymptomatic for some conditions. Not well, for example, if it's extrapulmonary sarcoid and they're asymptomatic, I guess I don't know how would that be. Maybe it's not a good example, but sometimes it's important to kind of keep in mind that some stuff that are asymptomatic, you want to treat them. Likely because they will cause some bad shit in the future if you don't. So, got a young female. She's been oozing from the margins of her wound in the ICU. She had a motor vehicle accident. Uh, One of the lungs is opacified, probably due to lung kind of like trauma, and not ARDS because it's only one lung. Has a bunch of bone fractures. Everything else is kind of okay. I mean, I'm thinking, we're all thinking DIC, so don't get too excited. INR is high. APTT is high. Platelets are kind of low. What do? We do a 1-to-1-to-1. We do give 1 part RBC, 1 part fresh frozen plasma, and 1 part. Oh, that's a question. Do we do a 1-to-1-to-1? Or do we 1-to-1? Meaning, do we give RBC or do we not give RBC? She's already has decent RBC. Maybe the ones, so if your DIC is as a result of hemorrhage, you probably want to give 1-to-1-to-1, meaning you want to give RBC too. But in a case that you don't have a lot of, you do have a lot of RBCs already, do you just skip the RBC? I would say so, because there's risk associated with just giving RBC. I'm wrong. You still give RBCs. You don't make a new protocol. It's always 1-to-1-to-1. 3 things. It's massive transfusion protocol. TIC, trauma-induced coagulopathy. Trauma-induced coagulopathy, okay. So you give platelets no matter what. So you give RBCs regardless of hemoglobin. So in traumatic blood loss, hemoglobin should be kept above 8. In trauma-induced trauma-induced what? Trauma-induced coagulopathy, you give 1-to-1-to-1 regardless of platelet or hemoglobin levels. Alright, always hate when I get a question wrong. Young woman, fever, night sweats. Does she have TB? I think she's. She has fever, night sweats. Sounds like she's had TB maybe in the past. She was at different Guatemala or whatever and got antibiotics and now has bone marrow failure, basically. She scratched the TB. She just basically had bacterial problem, got an antibiotic from a third world country, and now has bone marrow failure. The answer is what she got. The answer to the question of what she got is chloramphenicol because it's widely not used here anymore. Uh, oh, and it's meningitis, so they use chloramphenicol for meningitis in low resource settings. So this is interesting. It can happen in a dose-dependent fashion, or it can it can happen in a dose-dependent, reversible fashion, or in a dose-independent, irreversible fashion with sudden onset to many years onset, and it can be fatal. Imagine losing all your stem cells because you got because it's a fucking chloramphenicol cured your fucking stem cells. It cured you of having any stem cells. And it can be immediate or several months later, and it could be dose independent. So it's like a Steven-Johnson syndrome for your um, bone marrow, which you probably need it as much as your skin. I was gonna say more, but you can't say that because you'll die without either. Okay. Late 40s guy has cough and white phlegm for 4 months. Doesn't have weight loss or anything like that. Like chronic cigarette smoker. Does he have COPD is the question, like specifically chronic bronchitis. He does. It says, so I think for chronic bronchitis, for 2 years, you have to have several episodes of more than 3 months of like continuously coughing up shit. I think it's for 2 years, more than 2 episodes, each lasting 3 months. No, it's like not episode dependent. So 4 to 6 months out of a year for 2 years is chronic bronchitis. Oh, and this guy was a minor or something, no? No. He just smoked a lot. So chronic bronchitis is a type of COPD. So they should stop smoking, obviously. two right questions in a row. Please, I need 8 more to be able to sleep. This is beginning to be less fun. 33-year-old female, high-speed motor vehicle collision. Blood pressure is low, probably due to bleeding. Pulse is high. Has instability of the pelvic ring, broke her pelvis. Suddenly, she starts bleeding from everywhere, similar to the trauma-associated thing we had, trauma-associated coagulopathy, kind of similar picture here. Uh, says a pre-flow blood smear most likely to show what? Show what? Show what? So it's, I think it's a form of consumptive coagulopathy. So we're getting a helmet-shaped schistocytes. This is like a DIC. DIC as a result of bleeding alone. So this is DIC as a result of bleeding. That one is a trauma-associated coagulopathy, is because as a result of like all that fucking tissue stuff getting released, collagen products getting released into. Um, oh, and this one apparently is because of the transfusion, because she got. Oh, I guess I didn't pay attention, but this happened right after a transfusion. I thought this happened just as a result of bleeding a lot. So you get lucky sometimes with that, you know. It's part of life. Um, I'm looking at the other choices, seeing if the erythrocytes are stacked on top of each other in coined-like manner, aka Rulox formation. It's like multiple myeloma. I don't know anything else. Teardrop shape is like myelofibrosis, stuff like that, is because the bone marrow is fibrosed. Irregular thorny projections. This is acanthosis or echinocytes. Not acanthosis. Acanthocytes or echinocytes, whatever. Acanthocytes, which is due to what? Oh, this is due to like lipid problems. So alcoholic cirrhosis, avidolipoproteinemia, and apparently not. I think like vitamin E deficiency, all the things that are involved in lipid metabolism. Uh, let's see. Acanthocytes, right? Acanthocytes versus echinocytes. Who named them? Let's go to images. Cause. Okay, nothing shows up. All right. Right. That was the what, third question? Okay, let's see if we can get this one right. So someone has, old guy has chronic bronchitis. It's been getting worse. Uh, give a drug that contracts the vagal simulation. Vagal simulation is parasympathetic, so it's acetylcholine. So we got to give something that's like anti-acetylcholine. So tiotropium is the answer. Yay, 4 questions. Um, someone takes gets a hemicolectomy, or yeah, someone gets 6 days after like a surgery that they take half of your colon. Someone faints. After that, patient shortness of breath, deep aspirations. This sounds to me like a PE. Low blood pressure, low oxygen saturation, JVD, whole systolic murmur that increases during inspiration. It sounds to me like right heart strained. You're getting tricuspid regurg probably. And you have tachycardia. And you have a leg that's pitting, and you are having cold and clammy extremities, likely because of the circulatory arrest. What else do we see? Dilated right ventricular cavity. Yeah. So you gotta really think of that right ventricle working. I think it doesn't get enough credit. I think a lot of yeah. It's like yeah, right ventricle tries really hard, just as hard as the left ventricle. It's just we're prejudiced towards the right ventricle because it's smaller. We don't think of it as much. We don't think of it dilating. We don't think of it regurging like it is doing in this case. We really, as medical students, I think there's also the sign of decreased contractility of the right ventricle wall with a normal apical movements. Presumably that means like the left ventricle is beating normally, but the right one isn't. I think the reason that early on I got a lot of cardio questions right is because I really thought about the right ventricle a lot, like in step 1 level questions. No one thinks about the right ventricle now. Okay, so that was the 5th question. I'm gonna roll. All I need is another 5 questions. Actually, I don't. We'll see. 22-year-old woman. Coughing for 12 weeks. Whatever. Early 20s, coughing for 10 weeks. She doesn't have like doesn't get worse when she lies down. She otherwise feels well. She also has been getting runny nose. So does she have what I have? Does she has what I have? I have this, whatever it is. I think it's like postnasal drip. It was like it's coughing, but she's fine. Otherwise, she has like some irregular oropharyngeal patterns. What do we give her? Prednisone. I think she has something known as vasomotor rhinitis, which can be treated with oh, yeah, like an antihistamine. The only antihistamine it has is diphenhydramine. But you can't just give a young person diphenhydramine. It just like makes you really sleepy. I want to give her. The other thing is like GERD. Like, is this because of GERD? Is this whole thing happening because of GERD? She doesn't complain of maybe that cobblestoning pattern is a characteristic of GERD. You also don't want to give her. Might want to give her some. Hmm, 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 hmm. Yeah, I'm gonna go with diphenhydramine. I think it's a shitty answer. Oh, yeah, it's postnasal drip. I gotta figure out if this is an important thing because I definitely have it. Let's see. It says okay, allergic rhinitis, non-allergic rhinitis, chronic rhinitis, rhinosinusitis. How do you diagnose a chronic rhinosinusitis? That's the one you take get a CT of the head for. I think I have non-allergic rhinitis that's causing um. What's the difference between non-allergic rhinitis and vasomotor rhinitis? That's the question that you should be asking right now. Oh, I guess there's another subtype of non-allergic which is atrophic. That's they just atrophy for no good reason. It's either idiopathic. Shit, that would suck. Do I have that? Does my nose look atrophic to you guys? Is that why it fucking scratches sometimes? Or you can have it as a result of granulomatous disease, leprosy. Rhinoscleroderma? Jesus. I didn't even know that was a thing. Rhinoscleroderma. Rhinosclero. No. Most of the diseases that I know really well is because I thought I had them at some point. Or someone I know had them at some point. It's actually not a bad way to study. Like the right heart thing that I was talking about a moment ago, my grandma died of that because she had metastatic lung cancer. So I spent a lot of time thinking about how her right heart is strained. I'm only talking about this because I know no one is watching this. I miss you, Grandma. That's also why I likely want to do oncology. Not just because of my grandma, but because of like cancer being a big problem. You know, you don't die of broken bones. I mean, you would if there's like a lot of it, but it's not a systemic. Well, I guess it's not as big of a problem as cancer. All right, that was the sixth question I got right. In a row, in a row. 26-year-old. Whatever. 20-year-old has comes for a checkup, has type 1. He's from Nepal. We got a 280 on his step 2. He's kind of like a cigarette smoker. Don't smoke cigarette, kids. Hmm. So we do a PPD and we have a 12 millimeter like thing. I think the risk stratification is like people who have no risk. For them, if it's more than 50 millimeters, it's a positive. People who have a little bit of risk, which I think he falls into it, is like him being from Nepal or him visiting Nepal 4 weeks ago. And people who are super high risk is more than 5 milliliter. That includes people who've been next to someone who's had TB, or I think people who are severely immunocompromised. At least this is my like recollection of it. I really don't want to get this wrong. So I guess the next question will be, since this is positive, what do you want to do? Do you wanna? I think since we don't want to treat them because we don't know. I think we want to take a look at our lungs. I think that it's just the most fucking obvious thing. So lung X-ray. So exactly, because this guy has been out of like in somewhere that there's TB in the last 5 years. His threshold is 10, so this is technically positive. Uh, so like, dude, this literally says the next question is if it's latent or active. Literally what I was thinking. I guess like it's not that hard to think that. Dude, TB is a fucking bitch. I think it's probably has been evolving with us for many years. So people with HIV, immunocompromised individuals, or like taking immunosuppressives, or they have organ transplant, or who have had previous um, with a chest X-ray suggestive of TB, their threshold is 5. Drug users recently traveled, homeless, like prisoners, staff of a mycobacteriology lab, patients with diabetes, children for they are the normal risk factor. Where does exposure? And the next question shows a clear lung scan. Absolutely clear, beautiful, healthy lungs. What do we do? I think we just tell them goodbye. Oh, fuck, I got it wrong. I would have been the seventh question. So this is late. This is latent, bro. This is still latent. So you give him 3 months of, oh, dude, this is so bad. It means you gotta stay up all night. Did I fuck myself over by doing this? Only 25% of people got this right. So in the US, we also treat latent TB. But I'm assuming in a place that has a lot of TB, we don't treat that. So 3 months of INH plus rifampin or 4 months of rifampin is for latent. TB. Oh my God. We start from zero again. To question 7. This literally could last forever. Especially as I get more tired and I make more mistakes. Let's get focused, because I think I screwed myself. How long has it been? 2 hours and 5 minutes. I don't even know how the voice quality is. Can you guys even hear me when I talk? I wouldn't know. I usually have a microphone. I don't have a microphone now. Alright. So now we got like lady in her 50s, sharp chest pain, respirations are high, pulse is high, blood pressure is low. We have a large PE, large embolus on CT angio. We give TPA, then she develops right-sided weakness. And then question basically is, how do we reverse TPA? How do we reverse TPA? I thought it's a TNX. But what is aminocaproic acid? Is that TNX? Nothing else makes plasmin. Tissue plasminogen activator activates plasminogen into plasmin. Plasmin what does plasmin do? Probably breaks up clots, so we don't want to give plasmin. Give aminocaproic acid is the only thing that could be right. Antifibrinolytics. Okay, aminocaproic acid. Aminocaproic acid plus tranexamic acid, which is TNX. TXA. What is its name? Like its market name? Because dude, not in Australia, in fucking Freedom Land. Okay. I don't recognize the like market names. Are antifibrinolytics, antifibrinolytics, so they're antiplasmin. They stop plasmin from breaking clots up. Man, what a life I live in. Fucking New York, Saturday night. Filming myself doing questions. Daydreaming about Vancouver. computer is like 5,000 degrees. Okay. And then it can be used to, it is used to reverse TPA. Hopefully this lady's blood in head isn't gonna kill her. Dude, I'm screwed. Wait, my cumulative percentage is 80% on these 71 questions. I think I've done like 30 questions with you guys. The rest of it yesterday, maybe some earlier today before I started filming. Okay, 6-year-old woman. Cough, shortness of breath, whatever. But now has, exertional dyspnea. Okay. She's wheezing. FEV1 to FBC ratio is very low. FEV1 is really low. What's the likely diagnosis? It's emphysema, right? But it's not going to be that easy. Oh, X-ray shows no abnormalities. She have a fever or something? We don't know. Probably not then. She has smoked some cigarettes. She has an 8 year for 16 years. So she has an 8 pack year. Less than 10. Side effect of medication. No. I think she's alpha-1 antitrypsin deficiency. That's what she's getting. Emphysema this badly. And maybe that's why X-ray is not showing any abnormalities. But we'll know about that. And it's wrong. Fuck it. I'm not sleeping tonight, I guess. I'm just getting questions wrong all night. Which is fucking asthma, my fucking dumbass. She has cough. She has cough. This is recent. Also, she doesn't have any liver disease. She's normal. Fucking dude, normal fucking X-ray also. When people thought it's chronic bronchitis, they're really fucking dumb. It is asthma. So remember, asthma is also an obstructive pattern. But you want to see an improvement with bronchodilators. Right. This doesn't even worth writing down. 50-something-year-old, dry cough, shortness of breath. Okay. Water diarrhea, like some fever. What gives you like upper respiratory infection and also gives you diarrhea, like crackles, patchy infiltrates of both lungs. Some leukocytosis, some hyposodiumia, and then I think okay, it's a viral. So whatever it is viral. So it's fever. Okay, I got it wrong. I really wasn't expecting it to be Legionella. I thought about it because of the low sodium and because of I didn't know it caused diarrhea. So how do you treat that? You want to give levofloxacin. Nobody knew that, interestingly. So Legionnaires disease. Legionnaire disease is the intense version of Pontiac fever that I did notice a low sodium. I really thought about it. I just didn't think it's related to diarrhea. That's the problem. And I did notice the atypical pneumonia. Yeah, I don't know why I'm getting tired. That's why. And also, I probably knew that it's urine tested. And so it does go systemic. So it's not crazy for you to think it causes diarrhea. Atypical pneumonia, diarrhea, and as we can see, some that manifests with atypical pneumonia plus AKI, I'm assuming, plus I'm reading about this shit. Actually, let's just look at the photo. Diarrhea plus confusion, stupor, diagnosed with urine antigen, treat with Plural. Quinoa. Boom. Roasted. Okay, 50 year something year old. For 5 weeks, it's had intermittent fever, shortness of breath. He got antibiotics like 3 4 weeks ago, but it didn't help it better. Now has some bumps. Has rheumatoid arthritis, lives around New York. Crackles in the okay. Has like whitish nodules and eyes. I think blastomycosis has a lot of skin stuff. Yeah, this is blasto, and it gives the cauliflower like granulomatous lesions. Yeah, I was using histo on that. All the other ones are like geographically it could be histo or blasto. Cause I don't know if I said it, but it was somewhere in New York. So we got a 40s man, pretty feeling pretty fatigued for a year, losing some weight, no gaining some weight, fatigue, gaining weight. Okay, you have cushions or something, bro? Erythema of both palms. You have like fucking liver failure or some sort, like cirrhosis. Yeah, you do. Let's say carbohydrate deficient transferrin. Well, the liver makes transferrin. It's carbohydrate deficient. It's abnormal. So it's, I think if it's higher than normal, it's a sign of liver not working properly. And then also it's thrombocytopenia. Question is saying why. Two reasons why, actually. One of them everybody's thinking about is the factors that being made, like the platelet factor, because the liver makes that. The other one is that um, if he has cirrhosis, he has hypersplenism because the blood is backing up to the spleen, making the spleen be bigger than meaner than it needs to be. So hypersplenism. Even though this is not a hard question, but because it's people think of like the like um, you know how we have EPO, erythropoietin, we have thrombopoietin, and liver makes that. People are probably like thinking of that, and they're not expecting to see hypersplenism. That's why this is a hard question. So we got a young lady, like 20s, with jaundice. Um, she had a she had a viral infection that self-resolved. So I'm already thinking about what mono. Well, how could mono give you hepatitis? I don't even know yet. Maybe it's giving her hemolytic anemia. I still don't know. Kind of a guess at this point. Big liver and spleen. Yeah, I think EBV can cause hemolytic anemia. That's yeah. What if it's not EBV? What if that? Uh, what if it was like a strep, you know? But no, no matter what, she has hemolytic anemia because she's jaundice and because she's low hemoglobin, and decreased haptoglobin is an option. So I think that's the answer. But yeah. So yeah, of course, mono can cause cold aggravation as well as what? As well as what? Mycoplasma pneumonia. So mono and mycoplasma pneumonia cause mono, not mono, EBV, mycoplasma cause cold, cold agglutination. Uh, Cold agglutination, right? Yeah, I'm tired. Fuck. But but yeah, I'm not gonna give up yet. Cold agglutination and hemolytic anemia. Right. This was, I think, the third question. Yeah, our third question. So it's the eighth question because I see there's a C before. Looks like in 50s. So it's like, what do we give him for? Um, he's refusing heart. He was in Wyoming. Where the fuck is Wyoming? Probably somewhere in the Midwest. And the question says what prophylaxis do we give him? So we want to give trimethoprim sulfamethoxyl, as we talked about. For what? For toxoplasmosis, for PCP. And we might want to give fluconazole for coccidioidomycosis, but that's not an answer choice. We want to give azithromycin for MAC, but I think recently that's been like updated to not giving azithromycin. So the answer choice might just be trimethoprim sulfamethoxyl, but we'll see what the official word is. So we give TMP-SMX for pneumocystis pneumonia and toxoplasma under 100. Uh, Azithromycin under 50 for MAC. So this is the general information. And if he's not receiving heart, then he should be, I guess, screened for a bunch of stuff like coccidioidomycosis, histoplasma, and treat before. So just take your heart, you know? If I get something like this, I'll take my heart. Or tart. Or art. That was the fourth question. Yeah, four questions, right, baby? We got old man, old-ish, sore throat fever, it's painful swallowing. Grandson has parainfluenza. But he's like got supra epiglottis narrowing. which is the thumb sign. So high neutrophil count. Which is not diphtheria, which is not pertussis, it's the small is it yes. So a lot of old people are presenting with uh, this because the kids are getting vaccinated. Diphtheria. It's 5 questions, baby. 5 questions. I'm not gonna jinx it. 60-something-year-old man, fatigue, abdominal pain, have low everything, low leukocyte, low RBC, and then teardrop shaped cells. Uh, JAK2 mutation is present. This is myelofibrosis. So, what's the cause? Fibrosis in the bone marrow is the cause. Now we got a 40-year-old. We get retinoesternal chest pain in the PACU. There's 100% oxygen. Just bilateral wheezing. Patient's flushed. Did he have asthma or some shit? Well, the surgery was a nasal polyp removal. And he's given metope. So I think it's just asthma. So this is bullshit. He's given aspirin. Obviously, that's true, but it's aspirin exacerbated asthma, right? Not aspirinogenic asthma. Exacerbated. Yeah, I think metope is beta 1. That's what it why it's like mostly not fucks with your asthma. So it's like due to a pseudo allergy, which is like literally aspirin exacerbated asthma. But I just didn't think of it as like this quick of a thing. And my streak went up to 6. So I've had a 7 and 2 6s. I need a 10 to retire. Honestly, I think I'm gonna drop that before then. So a young kid, like a baby, can't breathe properly. He has apparently some sort of like candidiasis on his mouth. Leukocytosis. There's beta T glucan in his blood. So you have systemic candidiasis. Oh, he got prednisone for hemangiomas. He has a plaque that bleeds when scraped. How do we diagnose? Probably bronchoalveolar lavage, no? Yeah, but oh, it's pneumocystis. So beta D glucan is non-specific. This is for Candida, aspergillosis, and PCP. So beta D glucan is for Candida, aspergillosis, and PCP. All right. You want to do a silver staining. Which one was fucking PCP? Mm. There's silver staining. Shows cysts. Oh, that looks like discs. I gotta watch the fucking sketchy for that again. It was a ping pong one. Disc. Let's see. Hmm. This looks like a crushed ping pong ball. Like a way to remember it. I want to caption this video as I want to like watch me do questions until I drop something like that. Because I'm literally dropping. I've been doing this for 3 hours now. My hair. What's up with my eyes? Oh, that's a reflection. This eye looks a little weird today. Just literally closing shot. Can do this. Can do this. This. Look how tired I am. This is engineering. Actually, it's a probably good lesson about like psychotic eye movements. These are psychotic eye movements. Let's see if I can fake having a nystagmus. No, I can't. This is kind of cool. My slow nystagmus. It's pretty slow. Alright, back to normal. Wow, I can't believe you were looking at my eyes like that. Okay, I'm really tired. Fuck this. Okay, I give up. This is where I drop. This is when I dropped. I dropped.